So today, we'll be talking to Dr. Jessica Zitter and Reverend Cynthia Perrilliat. Dr. Zitter is a critical care physician and palliative care specialist in Oakland, California, who is helping to shape the national conversation about how we die in America. An author, advocate, contributing writer to publications like the New York Times and Washington Post, she is shining a light on healthcare disparities that can worsen the end-of-life experience for people of color and their families. Dr. Zitter is the author of the book Extreme Measures, and her work was featured in the Academy Award-nominated short documentary Extremis. Reverend Perrilliat is a healthcare change agent who leads the Alameda County Care Alliance Collaborative, a faith-based program that partners with clinical, academic, and community organizations in the San Francisco Bay Area to help meet the spiritual, social, healthcare, and caregiving needs of people with advanced illness and their families. It's one of several innovative programs the Reverend has created in a 25-year career focused on enhancing end-of-life care and educational training in the African American community. Reverend Perrilliat earned her MPA degree from Cal State University of the East Bay and is also an ordained minister of the Allen Temple Baptist Church in Oakland, California, and a gospel recording artist under her Splendor Records label. I always used to say after my introductions that, but I don't sing. But in fact, you do sing. So that's wonderful. So thank you both for being here. Our hope today is to have a somewhat informal conversation about the work that you're doing, about the impact that COVID has had on the work that you're doing, how the recent events of this summer with the protests and the reemergence of a real urgency around dealing with the issue of racism in the United States, as well as just generally and particularly in healthcare. So heavy topics, but hope that we can kind of dive in and see what we can do. So just to start, if each of you could describe your work settings and how your worlds came to overlap. How did you two meet each other and come together?
Cynthia, would you like to go first, or would you like me to?
No, why don't I think it'd be great if you go first, Jen.
Well, I am I guess I'm getting into the later years of my career. I've been practicing pulmonary critical care for a long time and added palliative care into my toolkit in the early 2000s, and really became an official palliative care clinician in the late 2000s, in 2008, when it really became an official subspecialty. And I think that my whole trajectory of work has been focused on the fact that I was in tremendous moral distress in the early days of my career. And in finding the palliative care movement, I was just lucky that it came at a time when I was really coming to a place that was unsustainable for me. And found this new approach, which is so focused on the whole patient, the whole person, the humanity of a person. It was just so not a part of how I was trained. I was really trained in an organ and disease-focused approach. And it really started to leave me empty. So with palliative care, I started to understand this new approach of focusing and celebrating a person's life. And in the last 10 years where I've worked at Oakland's public hospital, with, in particular, a chaplain who became my second mentor, a big mentor in my life. The first one was a nurse who really introduced me to palliative care. The second one was this chaplain Betty Clark, who works with Cynthia as well in some of her work. And she really led me to one of the bigger, role models for me in teaching me how to really let those ideas of what's important about a person fall to the wayside and instead come into a room in a way that was more full and embracing of the whole person. And so in that work, I have come upon the issue of racial inequities. It is such a scar on our system, and it's such a scar on the practice of healthcare. And as you start to look at it intellectually, it just is something that you can't turn away from. And that's how I met Cynthia, because I heard her speaking. We were speaking together early on at a conference, and I listened to her talking about some of the work that she's doing in the faith-based communities in Oakland. And I just ran up to her like a fangirl at the end of her talk and said, we have to work together. I love what you're doing. And so take it from there, Cynthia.
Thank you so much, Dr. Zitter. It's a pleasure to be here. So thank you so much, Jennifer, and your wonderful team. So I have to say, Jessica, I don't recall ever in our many times of having various talks that we actually have this point of convergence of what's important from a moralistic perspective before. But I have to say that I do very much relate to those words. So my story is one where, as a business person, and really believing in a holistic approach to health, which is basically how I was raised. When my dad was diagnosed with an end-stage prostate cancer diagnosis, at his first visit to the doctor's office, he'd had some symptoms that he somewhat ignored, but was feeling fine. And so he just kind of kept going until he couldn't ignore anymore. And my mom said, "Hey, you got to go to the doctor and check this out." Unfortunately, the prostate cancer had already metastasized to other organ in his body. So he got a very bad prognosis at his very first visit. And our family has been one, as I mentioned, this holistic approach to health and life. Our spirituality is tremendously important. Our health and eating right has always been important and stressed by my parents. And just the, mental development and just a really holistic approach to life. And so when Dad got this bad diagnosis, then our family went into gear to put our faith practices really to work. And we are believers in God, believers in Jesus Christ. We're believers in the Bible. But all of that was really and has always been very central and important to us as human beings. And so our story was one where Dad got 8 months to live because, again, it had metastasized. My dad lived 8 years. And I love having these conversations with Dr. Zitter and my other physician friends. They call us this outlier cases. And Jessica and I have some great conversations around this sort of thing. But we see it as a miracle. And so one of the things that was very clear to me when my dad did reach the last 6 months of that 8-year period, when we were introduced at a more deep level to palliative care and to hospice in particular, when Dad really did need hospice care, I actually did somewhat of an interview with the palliative care hospice team that came to our home. I was living in Chicago at the time. I'm originally from Toledo, Ohio, so I did, when I'd come home to help with caregiving responsibilities, I thought I'd take the time to really interview the folks that were there. First and foremost, they were all white people, and I thought that's kind of interesting, but not surprising. And so as I chatted with these folks, I found that really they had an incredible something, and I'll say something, in common, and that was they all identified with the calling. They were very wed to their work, and they were very passionate about their work. So from not my business background, but from my spiritual perspective, I thought, I'm starting to like these folks even more because I very much related to the importance of meaning and purpose and value in life. And I also had my marketing hat on that said people of color, particularly African Americans, and my work with Latinx individuals really have total mistrust for the healthcare system. And what I identified in our experience was it was a very positive experience. And so I saw a need, and our work is driven by responding to the need of communities, particularly communities of color, as it relates to what is palliative care, what is hospice care, what are the benefits, what are the myths and misconceptions, and how can we work together to bridge these gaps. And I know we're going to talk some more about health disparities, but how do we deal with these disparities and, frankly, medical mistrust? So there's so much to this. But of course, when I had the opportunity to meet Dr. Jessica Zitter, I have to remind her that I met her long before she tracked me down after that event where we were both speaking. And I had the real pleasure of becoming a community liaison for a hospice organization where I literally worked with the palliative care team, worked with the hospice team, talking to families about why they would want to consider palliative care and hospice care. So my history in this space goes almost 30 years because I had the real opportunity then to convince hospice individuals in a particular organization that they needed to hire someone like me that was really passionate about this work, but could position it through storytelling and listening, frankly, to communities of colors in ways that they could respond to that could be helpful in the long run.
So how have you worked together, the two of you? Are you, tag teaming, or are you going out together, or what's the program?
I'll start that one, Jessica, if that's all right.
Yeah.
So how are we working together? It's really exciting. So one particular focus of our work together is Jessica, through her very extensive work as a leader in palliative care. You mentioned, Jennifer, her work with her incredible book, which I refer to often, obviously the documentary Extremis. And so one of the things that we saw through the actual really medium of film, first and foremost, is powerful. And so in the work that I do currently, as the executive director and one of the co-founders of the Care Alliance for Alameda County, and of course, that work I didn't speak about, but I will in our conversation, really focuses on how to train people that are not medical folks, but are either faith-based or community-based, but really have a passion around helping people navigate the health system, particularly those that are dealing with advanced illness and end of life. And so in that space, our organization saw the real need for expanding the conversation around advanced care planning. And when we had the opportunity, frankly, to view Extremis, it literally blew our minds. First and foremost, we saw people that looked like us in the community. Number two, it was a setting that we're very familiar with, the public hospital in Oakland. And having had the opportunity when I worked in hospice to work in that space, it felt like, talk about a calling, it felt like I was really drawn to the space. But what Jessica has done so masterfully is to really capture the real life, actual stories that occur with people that either have made decisions around advanced care planning, advanced directives, PULSE, or have not. And so literally our partnership has come together to, frankly, build upon some great work Jessica has done in building a discussion guide for clinicians. We've come together to enlarge that to focus on the faith-based community. And so how do we use a discussion guide that springs from the key topics of Extremis to really share to faith leaders in communities the important roles that they can play? And I'll stop there as there's so many other topics that we've drawn out of that. And Jessica, it'd be great if you could continue that discussion.
I mean, it's you really summed it up so beautifully. It's sort of serendipity that, what I really feel is that taking story and film, powerful films, into environments where you can really change hearts and then change minds is very, very important. And so my focus is on trying to, frankly, improve the way we as doctors think about patients. And so I had a whole curriculum and discussion guide based on how do you help healthcare providers use a film like this to change or think about changing their behaviors. And so the idea of coming together with faith leaders and focusing a faith leader intervention, just like I wanted to focus on a physician intervention, to focus on a faith leader intervention where we enhance the understanding faith leaders are lay people, the understanding of what is actually happening in our healthcare. What do you need to know about the end of life conveyor belt, and really arm them, these lay leaders, with this critical information that frankly no lay people generally have, so that they can then go and do the important work of teaching their congregants. And eventually, our hope together, is that we can create interprofessional alliances and connective areas between physicians and healthcare providers and the faith leader community. Because what is sorely lacking in our hospitals, as we all know, 94% of people consider themselves spiritual, 71% of them are actually affiliated with a religion. We are completely ignoring that part of people's lives. And when they come into the hospital, especially when on top of it you layer the distrust that African Americans understandably have of our healthcare system, it is a recipe for disaster and bad communication. So if we can figure out a way to use these emotional priming tools, stories, films, experiences, and then bring together professional audiences in a mutual understanding, we could really start to make a difference.
We've been watching, all of us, over the past several months, all these events unfold. And I remember it was either a conversation you and I had, Jess, or maybe it was a Facebook message exchange. And it was early on, or early April, and you were kind of bracing to see what was going to happen next. And I wonder what it was like for you in the hospital. And what did you, how did you see the what we understand to be disparities and we understand to be challenges unfolding before your very eyes, in this new context?
Well, I was just saying this actually on the phone last night to Cynthia, that I went to get my own COVID test. I've been working in the hospitals and I was not feeling well, got a COVID test at Kaiser. And as I drove up, and they had this whole circuitous route, you come driving this way, driving that way, and they come with the swab to your car. Every single person standing there delivering this, doing this test was African American. And that said, I drove away from there crying, because I think that reflects perfectly. And there were many people there, probably 8 or 9 people. They were all African American. And, I just think that reflects a big part of what we're up against here. And that is that African American people, Black and brown people don't have the same layer of protection in their lives that white people have. And they are, when a disaster like COVID strikes, they have very little wiggle room. They're the first responders. They're living in what do we call it? In housing with many generations. They have to go to work. They have, and there's the environmental racism issues. And so so what have I seen? I've seen what we've all seen, which is the data that is so painful to look at, where we are seeing profoundly disproportionate mortality, morbidity in Black and brown communities from this virus. And I think that is, people have to take note of this. It's so striking and so alarming.
A phrase that has popped up. Sorry, go ahead.
No. I would just wanted to piggyback on what Jessica was sharing, Jennifer, and that is, the healthcare disparities we know have existed in communities of color, particularly the African American communities, for ages. I mean, this is nothing new. And what COVID-19 has done is it's just exacerbated. It's just shown people that really never fully grasp how serious the healthcare disparities are for communities of color. It's just highlighting this issue like never before. And so, I mean, that in itself is huge. People of color have known this forever. So when we talk about access and the barriers to healthcare access, we're talking about people that don't have the funds necessarily to, get the pre-testing possibly, or even the COVID testing as an example. I mean, there's so many layers. Jessica spoke about the multi-generational, housing and living, and people of color and Black folks are the ones that are the first responders many times as it relates to, be it the food industry or you name it. People of color are the ones that are out there doing the work in this environment and therefore getting sick. And so it's just, again, exacerbating the issue more and more. So I just wanted to highlight the fact that, healthcare disparities are not new to people of color. I know the healthcare system certainly understands that, but broader communities and systems, I think, are being able to see this in a new way. And then, of course, you asked the question, Jennifer, as it relates to, just the social unrest that is, directly connected to the racism that we've seen and known in this country forever. It is just a a moment that I don't think any of us could have ever anticipated would have come to pass. And for a person of color, such as myself, it's actually quite painful, frankly, to relive some of this, the George Floyd incident in our faces. But again, this is nothing new to the African American community. So, um, there's a lot of bad news, but there is some good news, and the good news is that a lot more people are becoming aware of the problems, of the issues, and frankly, a lot more people are having these kind of wonderful conversations that say, "Hey, folks, I mean, this is real, and what can we do?" As individuals and as systems and as policymakers to really affect change, because that's exactly what this moment is calling for, change.
Well, that's a perfect segue into my follow-up. That I hear this phrase getting tossed around in the press of the twin pandemics, or the
Mm-hmm.
twindemics of
Mm-hmm.
racism and COVID-19. And it does seem to me, and I'm hoping that some very bright sociological historian off in the future will be able to untangle this for us. That it does seem to me that the protests, which really crystallized around a moment that did not have to do with COVID, but nevertheless, there has been this. I think there's momentum being added from both events. So is that a valid sort of phrase to say twin pandemics? Racism, COVID, are they that closely related, or is it just kind of historical coincidence?
Well, I mean, I would just say that the pandemic of racism has been with us for 400 years in this country, and that it's neither, is it worse? Is racism worse right now because of COVID-19? I don't know, Cynthia. I'll leave that for you to answer, but I would say it's just being unroofed. The COVID, this extra pandemic has put a microscope on this this pandemic that has existed for 400 years in this country. And is it better? Is it worse? Cynthia, I'll let you comment on that.
Yeah, wow. I guess it depends on who you ask and on what day. The reality is, you know, it's it's a societal issue when it comes to focusing on Black people and other people of color. It's a communal issue, and it's also a very personal issue, depending on how an individual has been impacted. You talk about intersectionality. We've got people that are Black, that are LGBTQ, that are female. I mean, they'll have a different story than a heterosexual Black male, if you will. So again, it depends on who you ask, but I think if you talk about it from the perspective of a community itself, it's tremendously painful. So I would say it's added another layer, frankly, of pain. Um, we've seen in our work with working with folks that have advanced illness and their caregivers, we've always seen, I think all of us in our lines of work have seen caregivers pass away before the person they're caring for, just because, they're not caring for themselves very well. And so that has been exacerbated in this space where there's a lot of nervousness around COVID-19. Again, the lack of access to the healthcare systems. And even when individuals do have symptoms of COVID-19, their loved ones can't get in the hospital settings with them. And so, again, we're seeing that across the board, no matter who you are and what your ethnic background might be. But again, I think it's been layered. And then, oh my, don't forget we think about cumulative grief in the Black community. One of our dear friends, Reverend Corey Kennard, and I did a talk recently with the Hospice Foundation of America talking about the cumulative grief for the Black community. And that speaks to just the many intergenerational layers of racism and discrimination we've seen. And then when you think about all of that, we're really talking about complex trauma. I think everybody can relate to trauma in their individual lives and in the lives of their own communities. The Jewish community, right? African American community, Italians. I mean, you name it. Every ethnic group has trauma and has dealt with levels of trauma via, being immigrants coming to this country. But again, I think when you really narrow it down, Black Americans and communities of color just have dealt with this cumulative layering through the multi-generations from slavery to where we are now. And I think we're all seeing that there has been substantial change in many ways. I have to be honest, I'm one of those that have benefited from affirmative action. But boy, you have a group here today that would just, swear you down that it's the worst thing that ever happened. I wouldn't agree with that, and my contemporaries would not. So there's so much to say about this issue. But to your original question, Jennifer, yes, I would totally agree that it is a dual pandemic. Jessica made a great point, 400 years worth of it. It's hard to compare the two, but they both are huge, major issues and problems in our country. And frankly, it's helpful to have these kinds of talks, frankly, but it's also gratifying to see this incredible group of young people, all ethnic groups, that are lifting their voices and saying, enough is enough. Enough is enough. And if we really want peace, then we've got to have justice in this country.
Yeah. One of the challenges with, I was just going to say, one of the challenges with implicit bias is that it's sometimes unconscious. And this has been going on for so many years, and it is ingrained, even in people who are entirely enlightened and well-meaning. Nevertheless, there can be a veneer of prejudice, a veneer of bias and discrimination. So how does someone, let's just say in palliative care, or in end-of-life care, in serious illness care, how do we bring those biases into consciousness, and how do we extend that awareness across a team or an organization or a system so that by seeing it, we're able to change it? Because if we can't see it and don't recognize it, we can't change it.
Well, I'll take this one. This is, as they say, what in AA, if you don't recognize that there's a problem, you can never, I don't know what the exact word, but you have to start to acknowledge that this exists. And only then can we start to repair. And it has been, for me, a process of learning and humility, 2 steps forward, 1 step back, checking myself, talking to my friends, acknowledging it, feeling bad about it, and then moving forward to do something different. We were just talking last night about one type of implicit bias that I have been unlearning. Right? And actually the ACCA has helped me very much to unlearn this. Cynthia once said to me a little while ago, she said, what do you feel when you hear somebody believes in God? Does it make you think maybe they're less smart? And I realized, I said, well, first of all, I do too. I mean, I'm a faith-based Jewish person. So for me, it's not about intellect or IQ. But what I will say is that one of my sources of implicit bias has always been, and it's rife within the medical profession, by the way, this is not just me, that if you hear somebody say, I'm waiting for a miracle, or she's a fighter, or any number of phrases that you might hear, you make assumptions about what decisions this person is going to make about life-prolonging treatment, for example. You just jump to an assumption about this person's value system, which is very damaging. And I am completely guilty of having done that. I'm significantly better as I acknowledged it and started to challenge it. And frankly, it's not even that I'm challenging myself. It's that I've had experiences where when I've opened my mind, I've realized that I'm almost always wrong. So an example is when we went and we showed Extremis to a group of pastors at Allen Temple. This was, I don't know, a year and a half ago maybe. And
Yes.
I was having this conversation with this amazing pastor who came up to me afterwards and said, "Oh, this has it's been so helpful for me to learn about the end-of-life conveyor belt and to sort of understand more about what's going on in the intensive care unit." And then he started telling me a story about his family and about how he had someone had gotten very sick and they were in the hospital and they were trying to figure out what to do. And he said, and we started to pray, and we prayed and we believed that there were going to be miracles. And I got confused. And I was like, wait a minute, I thought we just had this conversation about the limits of the potential benefits when someone's dying of life-prolonging treatment. And so I asked him, I said, well, I just want to make sure I understand. Are you saying that you did want to continue this life-prolonging treatment in this person that you told me was dying? And he looked at me like I was not very bright. And he said, no, no, that's not what I was saying. I was saying that we were praying, but not, we took the tube out later that day. And it was just a perfect example of, again, and this happens to me all the time in the hospital, of you just can't take one thing that someone says, or one look that someone gives you, or the way they look, or the fact that they're a drug user, or whatever their variable might be, and make assumptions about them, because you are almost always wrong. So implicit bias is damaging, it's rife, it's partly a human thing. Chaplain Betty Clark tells me about her implicit biases about different groups. She's African American. This is something that human brains do. For whatever sociological reason, and we must use our cognition to undo that, because it's damaging and not helpful.
Yeah, thank you. I always just love chatting with Jessica, because she always speaks from her place of truth and speaks from her heart, and I really value that. And I think it also speaks to the humanity of just the notion of every single one of us being honest about our own implicit bias. I mean, you just said, Jessica, spoke about your own, and I have my own. We all are individuals that are human beings and have to be open, if you will, to view things from varying perspectives. And so what that means is that we all have to own up to having issues. None of us knows everything. One of the things that I often talk about in some of these various talks that I've engaged in as it relates to cultural awareness in healthcare, number one, it's important to be curious in a positive way about other cultures, and be very forthright, and from a sincere place, just get to know people of various ethnicities and backgrounds. I mean, we work and live in a state and in a country, but particularly those of us that live in California, in an environment where, you know, there's this incredible depth and breadth of people that come from various backgrounds. I mean, how cool is that? Man, I left my childhood home in Toledo, Ohio, to move to Chicago, work and other reasons, but that was a great experience. But Chicago is still very black and white, even though we work together. The community itself is still very segregated. California is quite different. I mean, we do have various Asian, African American, and Caucasian and Latina cultures, Latinx cultures that live amongst one another. So why don't we take advantage of the opportunities that we have to really just get to know people and understand that there's a lot we don't know, and there's a lot we can learn from one another. I think from a system perspective, I think leadership needs to just stand up and be leaders. If I could just put it frankly, I mean, in this hour, we need leaders to say, let's just look at how we process our work, how we do what we do as institutions. How can we affect positive change even in our policies? Can we go deeper in learning labs and learning journeys to get to understand one another, and have people that can come and speak to us, or people even within the confines of the organization to speak to these issues? I think this is the hour, if there ever was an hour, where we can take training to a much deeper level, and talk about openly these issues that have been so painful to discuss. If there was ever an hour, you know, a lot of people say they thought President Barack Obama would have opened up this race notion a lot more than he did. He's one human being, right? Well, look at us, you know, here we are, 2020, social unrest, right? COVID-19, everything is pushing this nation and this world, frankly, to acknowledge that we have implicit bias, that we have issues, that we do have police brutality, that because of the way of a person looks or the color of their skin or their size or their gender, they're discriminated against. Let's deal with those truths and
You
come
mentioned training.
really, yes, it's so
Yeah.
very important. And I think institutions can make a huge impact, and leadership has to lead and take the mantle and charge forward and really put some real thought and planning and engagement from a heart level. We need the mind and we need this mental engagement, but we have to come and bear our hearts and the humanity that we all share. I think you'll be surprised. I think we'd all be surprised. Jennifer, you won't be surprised. Jessica, you won't. But I think there are many folks that will be surprised that once we reveal our own humanity, gosh, we have so much in common. And that's a beautiful thing.
As an educator and running an educational institute, it is a challenge to think about how do you train, someone, how do you educate someone. And we actually, more than a year ago, we were looking at the feasibility of developing a course around these very issues: diversity, implicit bias, health disparities. And we did a whole needs assessment with interviews and surveys and so on. And the upshot of all of that was that everyone agreed that they had witnessed incidents of discrimination and bias and in their colleagues, and that education was needed. But of course, I don't need it. It's all my colleagues that need it. So as educators, it's challenging to figure out, okay, how do you take this even to the choir? Because the choir could use a little brush up on the singing lessons, I think, even so. And that kind of leads me into, what are a couple of essential lessons? What can we take from the experience of the last few months, from the awakening that we've had? What can we teach ourselves? What can we teach our colleagues? What can we teach our students, and our community members about this experience and how to get past it?
Well, I mean, for me, I think my greatest teachers in this experience have been my friends, and I think I'm lucky enough to work in a very diverse environment. I have people that I work with who are from many different cultures, and I work very closely with Cynthia. I work very closely with Pastor Corey Kennard as well, and feel a certain safety as I've gotten to know people of different backgrounds from my own as deeply as friends over time. And that has given me the safety and a real safe space. And you don't always have, if you don't have a safe space, you can't do this work. This is really important. And it's only if we can create really well cultivated safe spaces, whether it's because of true organic friendships, and not everybody works in a place where they are able to access people from different cultures from them. But if you can't, then the work environment needs to figure out ways to create safe spaces for people to, in a very unhurtful way, and also in a place that protects them, have these kinds of conversations. I think, when this is something that we're working on with this work that we're doing with the faith leaders and hopefully eventually doctors and other healthcare professionals, that taking examples of that you can see in a film, and especially if you can have vulnerable narrators, people who are willing to come out and say, like for example, in that scene in Extremis where I'm talking to the daughter of that woman who kept her on the ventilator, do you know that I cringe every time I watch myself in that moment? I don't feel that. I had tons of implicit bias going on in my head. I can tell you what I was thinking in that moment. And I'm a new person. I'm a different person than I was, 4 or 5 years ago. So let's use that as an example. I will prostrate myself on the ground and say, okay, mea culpa. I'm not proud of how I handled that particular situation. I think that you can even in Boise, Idaho, if it's an all-white environment, an all-white medical school, an all-white nursing school, you could have some sort of a conversation, whether it be videotaped and asynchronous, between people talking about that putting themselves out there and saying, hey, let's all be a little bit humble, a little bit vulnerable, with safety, so that we can actually start to talk about this. Once you do it, it becomes easier and easier.
Amen. I would echo everything that Jessica just said. I would also add that I think it's really important, and Jessica spoke to this when we first started this conversation. I am so proud to be a part of the palliative care community. I'm so proud to be a part of this healthcare field, particularly the palliative care community, and I'll tell you why. When I shared my story about my dad and how I began seeking out this space after having the experience of these incredible professionals that really cared and walked alongside my mom as primary caregiver, myself and my siblings as co-caregivers for our precious dad, I really and literally fully embrace the mind, body, spirit interdisciplinary approach to palliative care and hospice care. And I don't think that the field itself gives itself enough credit for just the beauty of the holistic approach. And I so admire and champion, the quote unquote founders, originators of the movement, um, in London and in the United States and just this entire movement. But I also want to challenge us that we have such a unique opportunity in this space. And I think that we talk about this holistic approach, which certainly um, was aligned with my and my family's values. But in addition to that, it speaks to the opportunity that we have to really lead when we talk about true person-centered care. If we really practice what we proclaim, then that means we embrace the culture of individuals as a part of their true personhood. That means we embrace the spirituality of that individual, whether they're a Jew, a Christian, an agnostic, an atheist, whatever that means for them, right? We honor that and acknowledge that. We acknowledge the health issues with the body itself. So again, that holistic approach, palliative care is an amazing um, field of medicine, specialty area, but it has amazing people in the space. So I think when it comes to this training, this learning opportunity, I think we have to practice where we are and start with our teams. And let's dig deeper in terms of how can we listen more to the social workers, and how can we listen more to the chaplains, and how can we learn to listen more, right, to the patients and the families, and how can we give the physicians that aren't as humble as our lovely Dr. Jessica Zitter, but help them navigate their own humanity, and it's okay to be human. We know the medical school doesn't train them necessarily to be human beings. They train them to be scientists. And both can, right, coexist in the same space. So there's so much we can learn in this interdisciplinary approach. And Jennifer, you asked about, you talked about the teams and your needs assessment with your group of folks there. I think that's so important. I also would add that right inherent within the interdisciplinary approach to the work, from a medical and an academic perspective, there's a lot of work we can do, and we need to bring that to healthcare as a whole. Oh my God, palliative care is the lead. I'm sorry. I will always believe that because you come from a holistic perspective. And I just wish we could see ourselves and the opportunity that we have in this incredible space.
Well, thank you for that. Yeah. Yeah, I do think that we have some work to do there, actually. I mean, because even palliative care is often challenged to fully embrace the spiritual perspective in particular. I think it's nationally only about half of inpatient hospital palliative care teams have an assigned dedicated chaplain on the team. And that is something that needs attention and needs to be reinforced. But you're absolutely right in bringing the holistic perspective, the whole person perspective, the patient perspective to the rest of healthcare. So we're just about out of our time, incredibly. Any last thoughts from either of you to kind of pull things together and wrap up our journey today?
Well, I have something to say, which is I'm inspired. I feel, I mean, as with recent world events and current world events, I can move into places of despair at times, but I have to say, I think sometimes it's darkest before the light. And I do feel that we have many ingredients right now that are ripe for the taking. The fact that palliative care exists as a movement to lead the way, possibly. The fact that people are now white people. You go, Corey Kennard said, I was driving through Grosse Pointe, Michigan the other day, and he said there were Black Lives Matter signs everywhere. He said, I couldn't believe it. The fact that there is an awakening of the white community to saying this is not okay. This is new. Our younger generation is so much more literate about all of these things that we're talking about already. I look at my children; they're just much more. They're much more agnostic. I don't mean from a religious perspective, but I just mean in terms of judging people by outside variables. So I feel a lot of hope, and I particularly feel incredible hope in that I'm excited to do so much work with Cynthia going forward.
Thank you, Jessica. I can only mirror that. I so agree, and I just think it's wonderful, and I hope that our opportunity to share today is a reflection of really the great possibilities also in our willingness to partner with CSU, my alma mater, and also just the medical and academic community as a whole. I think there's so much that faith-based community and community as a whole can lend to the space and the conversation. So we're just chomping at the bit and excited about the opportunities ahead of us.
Well, thank you both so much for joining us and sharing your insights and your experience and helping us provide this education and engaging in research on these topics in palliative care and in what's happening in the world around us. It really is pretty remarkable. So we're very much looking forward to being back together in person, we hope, next year at our symposium. and hope you may be able to reprise your appearances in real life, as it were. So thank you all so much.